Okay, so let's talk about grade 3 tears of the ACL. It can be proximal, mid-substance, distal. You can also get distal bony avulsions. And so here, if you are familiar with the ACL, PCL, this is a chronic ACL. We can see that instead of going up to its attachment on the femur, it's inferiorly displaced here. It's coming over and attaching to the PCL. And we know that it's chronic because we see there's no edema. The soft tissue planes and the fat planes are sharply defined here, so that's a typical chronic type tear. Here we can see another chronic proximal ACL tear, which inferiorly displaced and adhesed over here to the posterior cruciate ligament. So these are kind of chronic changes where we can see that the soft tissue planes are pretty well defined here with a lot of acute edema and scarring. The other thing, this is a kid with a chronic ACL tear, and here we can see the ACL is inferiorly displaced over the tibial spine. We don't see anything going up to its normal attachment, and that's another pediatric chronic ACL tear. Another sign that was popularized by Philip Tierman is in the axial plane, where if you follow the ACL all the way up to where it should attach to the femur, at all locations you see fluid surrounding the ACL. It never actually comes to attach to the bone, and that's called the Tierman ring sign of ACL tears. Okay, let's see here. Jake, why don't you start out today?
All right, it looks like, I don't really see an ACL in this image. I just see like an amorphous mass without distinct fibers.
I agree with you. This was kind of amorphous there, posteriorly. You can see that there's an MCL tear. We're a little bit too anterior to see the lateral collateral ligament, but I'd be certainly concerned that there could be a problem with that as well. We can see that there's a peripheral tear of the body of the medial meniscus. Which we can follow this all the way back here. And if we follow it all the way back, we can see here that there's some bone edema in the posterior medial tibial plateaus, which is should make us be concerned about a pivot shift mechanism of injury. A little concerned about the posterior root attachment here of the lateral meniscus. And if we go, so I think I missed something. On the sagittal images, we can see here's the tear of the ACL. Fibers are indistinct. The proximal fibers are very thickened. So this is primarily mid and proximal substance tear of the ACL. Here we can see a vertical injury of the periphery of the posterior horn. This was that vertical tear that wrapped all the way around posteriorly. And the setting of an ACL tear, posterior horn of the medial meniscus, this would be a root tear, which we've a ramp tear, which we've already talked about before. And it involves both the superior and inferior articulation. So this would be a little bit of an unstable ramp tear. In this particular case, we also see that we have a delaminated tear of the articular cartilage of the medial femoral condyle. So in this particular case, this is one of the few cases I've seen over time where we've actually seen the medial collateral ligament tear, ACL tear, and medial meniscal tear, which is O'Donoghue's unhappy triad that Dr. Yagudas talked to us about last time. Okay, here's just a patient who came in 8305. The ACL was intact, came in a few years later, and here we can see this is a mid-substance tear of the anterior cruciate ligament, intact mid-substance, and you can see where the fibers are disrupted here due to the acute tear. Here's another mid-substance tear. Here we can see fluid going all the way across the tear. Now, when we talk about treatment, one of the reasons why it's thought to be that it's very hard to repair an anterior cruciate ligament tear is that joint fluid, even though the ACL is an extra-articular, it's intra-articular extrasynovial structure, often when you tear the ACL, you also tear the adjacent capsule next to it, and you'll often get fluid from the joint space going in and bathing the area of the tear. This tends to dilute any molecules that are important in the healing process, and that's thought to decrease the chances of ACL tear repairing itself. Though we'll see some examples where it does, but generally it's thought that the ACL will not repair itself, as opposed to the medial collateral ligament, where it's now typically they're treated conservatively for that reason. Okay. See, did Robert do the last one? Jake did. Okay, Robert, why don't you do this one?
All right. So I see another mid-substance ACL tear, large joint effusion, maybe some edema in that medial femoral condyle, and lateral tibial plateau.
Medial femoral, you mean in, oh, we don't, here's the medial femoral condyle over here, I guess. Maybe a little bit here.
Sure.
Okay, so here we can see a proximal and mid-substance ACL tear in this patient, right in there. Here are the sagittal images. What do you see here?
Here I see some edema in the lateral femoral condyle and posterior tibial plateau, so I'd be concerned for a pivot shift injury.
Right. So what happens with the pivot shift with the ACL tears? This portion of the lateral femoral condyle subluxes posteriorly with respect to the lateral tibial plateau, or the lateral tibial plateau subluxes anterior with respect to the femur. Depending on how you look at it, typically in the orthopedic world, it's considered that the tibia, well, in the setting where this is an injury where the foot is planted, then the stable bone really is the tibia. And so you end up getting a posterior rotatory displacement of the femur with respect to the tibia, which is planted on the ground. And it comes back in this part, this anterior articular surface of the lateral femoral condyle impacts the posterior aspect of the lateral tibial plateau, and you get these kissing injuries caused a pivot shift mechanism. That's due to the ACL tear. The femur shifts, rotates, and pivots posteriorly and impacts back here. So you tend to get impaction injuries of the lateral and also the medial tibial plateaus. In this case, there's also a tear of the posterior root attachment of the lateral meniscus as well, a little bit of displacement, and this is the medial side in this area. So this is a typical pivot shift mechanism of injury, which is classic for an acute subluxation event from anterior cruciate ligament insufficiency, and often you'll see a little bit of bone edema on the medial side as well. And here we have a vertical tear of the posterior horn of the medial meniscus, which is characteristic of the ramp tear that we talked about before. Again, it's a shearing injury due to the pivot shift mechanism of injury. In this case, we've got an acute hemorrhagic effusion within the joint space, and so that's kind of a classic acute tear. Taysom?
All right, so it looks like we have a complete mid-substance tear with intact fibers distally
Okay.
and large effusion.
Large effusion. Good.
Let's see.
So the other thing you see here is a lot of edema in the posterior soft tissues.
Uh-huh.
So if you have, especially if it's a young person and this is their first really knee injury, when you get an acute effusion in the joint space, which is typically hemorrhage in that setting, you can also get a rupture of the posterior capsule and get extravasation of the effusion into the posterior soft tissues. The reason this is important to describe is if you have a capsular tear and you want to do acute arthroscopy, you can have some risk of developing a compartment syndrome if you start pumping the joint space full of saline under pressure to do an arthroscopic study in the setting of an acute tear of the capsule. So it's worth commenting on. In reality, most people like to wait 4 to 6 weeks now before they do an ACL repair. In fact, they want to wait till they get full motion back, because if you do a repair too early, then you tend to get arthrofibrosis much more commonly, and it's much harder to get full motion back in the knee. So nowadays, you usually wait 4 to 6 weeks before you operate anyway, unless there's some reason why you need to operate sooner. But it's worth noting the soft tissue edema here, just so everybody has a heads up that there could be a capsular injury.
Okay, so here we see, I think, a mid-substance tear of the ACL.
Okay, here are coronal images.
I see, yeah, so bone marrow edema at the bilateral tibial plateaus and lateral femoral condyle. Yeah, compatible with a pivot shift injury. Oh, yes. So looks like a bony avulsion of, yeah.
So here's a Segond fracture.
Mm.
It can be kind of subtle. And it's not a big miss on an MR. It would be kind of a big miss on a plain film, because if you miss on, I mean, it's indicative that the patient has an ACL rupture. So you could miss the diagnosis on a plain film if you miss it. On MR scan, we see it itself. So it's not a huge miss, but this is what a Segond fracture looks like on MRI.
It looks like here we don't really see.
Okay.
We don't really see the proximal fibers of the ACL.
Yeah.
So my guess would be proximal.
Though you probably wouldn't want to make that diagnosis on this image. What else do you see here elsewhere?
So I see bone marrow edema in the lateral tibial plateau and lateral femoral condyle, and then there's looks like some extrusion of the body of the lateral meniscus, but some, I don't know, some joint effusion adjacent to that meniscus too.
This structure right here.
Is that the
Yeah, this is the interlateral ligament.
okay?
And what's happened here?
Oh, bony avulsion of that.
Yeah, so this is another Segond fracture. What it looks like on an MR examination. And here we can see that Segond fracture over here. And here we can see there's a lateral collateral ligament. Here's that anterior lateral band coming down, and that's where the fracture is on the sagittal images. Okay. Another thing that can be injured when you have an ACL tear is the distal iliotibial band. And it's important to realize that the iliotibial band attaches to 3 different locations distally. One is called the proximal femoral attachment, where it inserts on the posterior proximal lateral femoral condyle. It's kind of a catty-corner to the adductor magnus attachment on the medial side. And then there's an epicondylar femoral attachment, and then the main attachment that we look like, which is on the tibia, called the capsular osseous layer on the lateral tibial plateau. And injuries to the proximal femoral attachment posteriorly and the layer which attaches to the lateral tibial plateau can be injured in the mechanism which produces with the pivot shift mechanism that you get with ACL tears. Robert, what do you think of this case?
All right. So it looks like the ACL is probably torn.
Okay.
There's like a fluid level in the joint, so lipohemarthrosis.
Okay, there we go. Here are the coronal images.
And on the coronals, kind of looking at where the IT band inserts, it looks like there might be like an avulsion of that area.
So
A lot of
that's an avulsion injury of the iliotibial band. Good. And if you go a little bit farther, we can see on the next cut, we can also see that avulsion fracture at the insertion of the iliotibial band. If we go back posteriorly enough, we actually see there's a little Segond fracture in this patient as well at the ALL attachment. Okay, Tayson.
All right. Looks like there is disruption of the ACL fibers at the distal insertion on
So
the
it's
tibia.
it's a little bit more subtle, but actually that's right. There's a little distal injury here to the ACL fibers. It's a distal tear. Now, here the distal tears, they can either be tears of the tendon at the bone tendon insertion, or they can be bone avulsions. And it's an important distinction because the bone avulsions typically will displace, and as we'll talk about now, those are best treated surgically by reimplanting the bone onto the tibia. The soft tissue bone attachments tend not to heal very well, and these are then if you're unstable are treated like a classic ACL tear with a graft placement. So whether the bone's involved or not is important to distinguish. Here's another case where we have a soft tissue tear of the distal attachment of the supraspinatus tendon. Here's a retraction of that tendon. And again, this is typically treated by graft replacement. Okay.
So we have a young patient. I see. Yeah, I'm not seeing clear fibers of the ACL. Maybe there's a tear at the proximal attachment
Well,
there.
yeah, we're not seeing this real well here. Let me just tell you, in kids, the ligaments are generally very strong. The weak point in kids is more the bone.
Mm.
So what we actually see here is a bony avulsion of the attachment of the ACL here. And on the coronal images, you can see that bony avulsion fragment right here as well. In this case, it's non-displaced. So some people might treat this conservatively since you don't really want to operate on kids, but you want to follow it carefully to make sure it heals without displacement, as we'll talk about in a minute. In this particular case, if they did plain films and stretch it with flex views, you can see that it's actually unstable. That bone actually moved and retracted.
Mm.
So you'd have to be very careful here. When you see this in this particular patient, when they saw this, I think they went in and tacked it down so that it would heal without displacement. Okay.
Here we see another avulsion of the ACL avulsion fracture.
Yeah, here, this one is displaced, as we can see here. This is a rare one in adults. It's very uncommon to have these bony avulsion injuries in adults. This is more a pediatric injury. But this with a displaced like this, these typically need surgery, but it's not a graft placement. You tack the bone down because bone heals very well to bone. Robert.
Let's see. I think there's a little, irregularity of the articular surface of the tibia,
Yeah,
ACL.
this is really in the notch of the knee, so we're not really seeing the articulation part, but we see the ACL coming down here. This is medially. If we go to the next cut over, it looks like this.
Yeah, looks like there's an avulsion fracture of that tibia plateau.
So here's one where the anteromedial band attaches normally, but the posterolateral band has avulsed a piece of the bone here. And on the coronal images, it's a little bit harder to see, but here's a little piece of bone that's been lifted up over here. And again, this could be unstable. This is in a kid, so they have to be aware of this and have to make the decision whether they want to risk this healing abnormally by treating it conservatively or operate on it.
so looks like we have an avulsion of the tibial spines.
So again, another avulsion, kind of like before. This is on 9/22/05. Here the okay. Now the patient came back on 12/13/06, so a little over a year later.
Non-union of that fragment.
Right. So this is a non-union. So this is the reason why you usually want to surgically fix these down. In the acute setting, the bone will heal very readily as long as it's opposed and stabilized. Once you get in a chronic setting like this, where you have cortex all around it, it's much harder to get that bone to heal properly. So you typically prefer to treat these in the acute setting and not wait till they become chronic with chronic instability like we have here.
Okay, sagittal radiographs. Yeah, looking at the tibial plateau here, I don't. So, let's see, is that, I don't know, I'm not sure if that's,
So here's the plain film. Here's the MRI.
okay. Okay, so that tibial imminence there, maybe there was a fracture and it's healed because it looks deformed.
Right. So this is actually a case where you had a bony avulsion of the ACL
Hmm.
and it healed displaced. Now, this patient had trouble fully extending their knee. That's called a extension block. Now, we wanted to get a CT scan, so they brought the patient in and did a CT scan, but they CT'd the left knee, not the right, which was actually very helpful for us because that's what it looked like on the left side, the ACL coming down, and that's what the normal anatomy should be. And this is the symptomatic side. So this is a healed ACL avulsion, but it's healed abnormally in a situation they get an extension block. Extension blocks greatly increase the risk for degenerative joint disease. So they basically have to go in and refracture and put this back down again. So these bone avulsions are important to be treated properly the first time. I'm just showing a bunch of these because a lot of people don't see these because these are more in pediatric cases. And I just want you guys to see they can all look a little bit different and sometimes confusing. So I want you to see several different ones and what they look like.
So again, we see here a avulsion fracture of the tibial spine with a bunch of bone marrow edema.
So that's 3/14/11. Here we can see there are a lot of other bone injuries in this particular patient and retracted displaced bone fragment. Okay, so this is 3/14/11. Now this is 3/23/11. Over 2 weeks later.
It looks to me like there's a bunch of fibrous tissue within that. Okay, well, this image, it looks like it's kind of tacked down.
Right.
So it looks like it's well healed,
Yeah.
I would say.
So this is the acute injury. We have a displaced fragment. In this patient, this is also an adult. This is this fragment on 3/14. The patient then went into surgery. These are the postoperative images where we see there's still a little bit of displacement, but you can see where they've tacked the bone down here with a bone tunnel and sutures coming out to a plate over here, a little button over there to tack it down. And here we can see that the ACL is now coming all the way down to the bone, so that bone's tacked down again. So that's, you can see some bone edema from the trauma. So that's an avulsion repair. Roberto.
All right, so we have a 40-year-old female, 4 weeks after a sports injury. And I see an ACL tear.
Okay.
Looks like there's some pulsation artifact. Looking at the, I guess, posterior meniscus. What it means is- Was it lifted?
Okay, so these are the sagittal. Here's the coronals.
So it looks like there's probably a tear in the posterior root.
Yeah, so this is a root tear, and then here, so ACL tear. So when you get ACL tears, there are a lot of other things to look for, like we've talked about, the bone injuries you look for, and you look for tears of the posterior horns of the medial and lateral menisci. A common injury is a root avulsion or root tear of the lateral meniscus. Another common injury is a ramp tear, peripheral tear of the medial meniscus, and both of those it's important to detect because at the time of surgery, if you do an ACL repair, you need to repair those two meniscal injuries as well. And then this just shows, in this particular case, that's the root attachment there. Now we see no meniscus back here going down to that root attachment. Here we can see the lateral meniscus is not there really, and then all of a sudden we see it again. And then on the coronal images, we can see that root tear with the displaced meniscus back there, then all the pivot shift mechanism of injury. Good. Okay.
All right, so the ACL looks disrupted mid-substance.
Okay.
Yeah, and there's a contusion in the
Pivot shift.
lateral femoral condyle.
All right. Here's on the medial side.
Medial side looks like we have a vertical tear peripherally in the posterior horn,
Okay.
so a ramp lesion.
And if we go to the lateral side, what are we seeing over there?
Is that a little meniscal flap?
And then here we can see kind of the funny appearance here. Something. Here we can see that lateral meniscal tear in the coronal plane. There's a pivot shift mechanism of injury. So this patient had multiple meniscal tears. This is an unstable flap tear where you can see it flip back on itself, and vertical longitudinal tear there. So a lot of injuries. And generally in young people with acute ACL tears, you want to repair the meniscal injuries if at all possible. So sometimes if they feel that there are a lot of menisci repairs that are needed, they will do the ACL surgery sooner than later because you have much better chance of getting a repair of the meniscus if you do it within 2 weeks than if you wait later.
Okay, so here we again, an ACL injury. Okay. Looking at the lateral. Okay.
No. I don't know when I did that. Oh, okay.
Hmm.
So this is an ACL tear, like you said. The medial meniscus is intact. This is on 10/14/09. Now the patient comes back a little bit less than a year later, and this is what it looks like.
Yeah, so okay, so the ACL, I mean we see some fibers, but I
Right.
think it's still
Yeah, so here's the tear before.
mhm.
Now we can see that in the area where you have that tear, there are some fibers with the meniscus. The ACL looks very bowed here, doesn't look very taut.
Mhm.
And so you can get healing of the menisci occasionally, of the ACL occasionally. We'll talk much more about this probably in the next lecture. But if it often will heal in a stretched out position where you still have instability of the knee. So here we can see that there was some healing or scarring in of the ACL, but let's see what else we see in the knee. So this is 8/19/2010. What do you see here now?
Well, there's a tear of the where are we? Is it the medial meniscus there?
Okay, here's the medial meniscus.
Wasn't
So there's a tear now, whereas 8 months earlier there was not torn.
right.
And then we can see a lot of degenerative disease here. So what we do know about meniscal tears is if you have what we know about ACL tears, if you have an ACL tear, you have increased risk for degenerative disease in the knee, but that's somewhat controversial. what is not controversial is if you have an ACL tear with secondary instability that's not treated, you have a much higher risk of developing then a new meniscal tear than if you put in the graft and stabilize it. You probably have increased risk for degenerative disease as well, but the data is much less clear there and controversial, but you certainly have increased risk for meniscal tears. So, but we'll talk more about that. We'll talk later about what predisposes to degenerative disease in knees on later talks. So then basically, now you can type ACL tears, and that's generally with the proximal, mid-substance, distal, or bone avulsions. And the proximal tears where you tear the very proximal ACL or it avulse it off the femur. I've never heard of or seen a bone avulsion from the femoral side, only the tibial side. But some people now are treating those by repair rather than by grafts if they're right at the very proximal aspect. And we'll talk about that. So here's some studies looking at whether there's increased risk for osteoarthritis after ACL injury. This particular study, they showed a six-fold increased risk after an ACL injury. But that's the same degree of increased risk that you have of developing degenerative disease after you have a traumatic meniscal tear. Now, and this is an acute meniscal tear. That's different from a chronic degenerative tear. We've already talked about the chronic degenerative tears that tend to be treated best by not doing partial meniscectomy. Acute tears of the menisci are much better treated by primary repair, where there are some studies to suggest that you markedly decrease the progression to degenerative disease if you do a repair, but not a partial meniscectomy. So if you treat ACL grafts with, ACL tears with grafts, you can effectively stabilize the knee. Now, with modern techniques. But the problem is that in order to properly, effectively stabilize the knee, you have to properly position the femoral and tibial tunnels so that the orifices of those tunnels are at the native origin and insertion of the ACL, because that's the isometric position, which I think we're going to talk about in a minute, where the distance between those 2 points stays the same throughout flexion and extension. If you put it anywhere else, then it's not isometric, so in flexion it'll either be taut or loose, or extension it'll be the other way around. So you tend, if the grafts are not perfectly placed, you'll tend to get stretching on the graft in one position and laxity on another, and that has a tendency to then produce degenerative disease and eventually tearing of the graft. Grafts do decrease the risk of subsequent meniscal repair. It's not clear whether they decrease the risk of degenerative disease. And a lot of these are probably due to studies back where the techniques that were used to do the graft placement were not careful about where the tunnels were, and therefore they were not in the isometric location. And what they found in this particular study in the New England Journal of Medicine in 2010 is that two-year outcome in young athletes is not improved by early reconstruction. I really strongly believe right now that the outcome is much better in young athletes if they get a proper reconstruction early, rather than not reconstructing it. And we followed some players, some NFL players, including some well-known players for the Rams here, that just did not do well over time without ACL grafts. Even though they were very strong and they felt they had stable knees clinically, they ended up limiting their career early on. ACL grafts with degenerative disease, abnormal anterior translation persists in up to 50% of postoperative knees. Again, that's primarily data from times when people were less anal about the positioning of the graft orifices. Abnormal tibial rotation persists in up to 25% of post-op knees. Now, the rotation tends to occur if the femoral graft is too high up. If it's near the 12 o'clock position, then it no longer stabilizes against rotation because it's right in the rotation plane, so you tend to get a lot of rotation. So the positioning in the coronal plane of the femoral tunnel should be over around the 10:30 to 11 o'clock position, and that will help decrease the risk for rotational instability. And then if you have an unstable knee, you increase the risk of cartilage disease. Okay. Is Jake next? Or?
This 38-year-old female, one day after a skiing injury. Looks like there's laxity proximally, or laxity at the distal ACL with a tear of the proximal insertion.
So, and here we can see there's a little pivot shift, bone edema. And here we can see that ACL tear on the axial images. Okay, so this is that same patient on 5/13/15. This was 3/23/15. This is less than 2 months later.
So it looks like, it looks like it's fairly well healed. I can see fibers going proximally to the origin.
And here you can see it looks blacker, looks more normal on the axial images. And a lot of that bone marrow edema is mostly healed at this point. But this is basically within 6 weeks, you're having some healing of this proximal tear. So there are some people and some studies that suggest that these proximal tears, especially in kids, can be treated conservatively and they can heal. The problem is that it's not very reliable. And in fact, there's a well-known knee orthopedic surgeon who was a U.S. ski team doctor for many years, Stedman, who had a procedure where he would just take his little finger at surgery and kind of push the ACL up in a lot of young patients and get it to heal with just physical therapy. He called that primary healing response. But that's not considered standard of care right now. But there are people trying to look at ways where you can make this repair reliable. And most people believe that's by keeping the joint fluid away from the area of healing and stabilize it for a long enough time so that you can get good healing. But that's still controversial and is not considered standard of practice. Robert.
Yes, it's a 38-year-old LB Clubhouse manager, knee pain, positive last test. Looks like there's a mid-substance ACL tear.
Yeah, right in through here. This is on 9/23/2011. See a lot of increased signal intensity edema within the ACL on the coronal images. So this is on 9/23/11. There's the abnormality. There's the abnormality on the axial images. So he declined having surgery, and he came back 2 months later, and this is what it looked like.
It's like it's intact now.
It looks like it's pretty taut, doesn't it?
Yeah.
Actually, he was quite happy with the results. And last time I talked to him was a couple of years after this. And he did fine without ever having surgery. But these are the exceptions, especially the mid-substance tears really are exceptions to the rule. Okay, Jason?
All right, there's a positive arrow sign at the distal attachment of the ACL, and the fibers look very lax proximally.
Okay, so this is a tear really at the soft tissue tear at the insertion of the distal ACL onto the bone, right?
Yeah.
So this is typically treated with graft placement. This particular person came and we talked about this kind of at length. He saw a very well-known knee surgeon in the area who recommended graft placement. He decided that not to do the graft, but to wait and see if this would heal. And and he could always do a graft later. So this was on 3/15/2013, distal ACL avulsion. So we brought him back a month later. He's an employee at RadNet, so it didn't cost him anything. And what do you think now?
I think the ACL looks intact and pretty taut.
So it looks like that kind of healed, and it looks reasonably taut. And at this point, he was relatively stable in physical examination and actually was feeling pretty well, though the surgeon wasn't very happy with me. So this is what it looked like 4/13. So he'd started physical therapy at this particular point. This is what it looked like a month later. What do you think there?
I think I'm getting a little bit more increased signal mid-substance than before.
Yeah, but the area
But
of
the area,
injury is
yeah,
pretty good.
looks good. Yeah.
Okay, so this was in 2013. So this is, yeah, so this is 2 months after the injury. He's a semi-pro tennis player, and he actually injured himself playing basketball with his kids. So 5/13. So then I asked him to come back 7 years later. And when he came back 7 years later, we can see that there's a little bit of attenuation here of that ACL, but the distal insertion still looks like it's intact. He has a little bit of degenerative disease in the knees, so I don't think it's perfectly normal. But the data suggests that he's no worse off than if he had had an ACL graft, where it's known that you have significant increased risk of degenerative disease in the knee, especially patellofemoral disease, if you have ACL graft placement. And we're actually doing a study right now with USC looking at why that's the case, and we think we are getting an idea of why you increase your risk of anterior compartment disease when you have an anterior cruciate ligament graft. It really changes the contact surface between the patella and trochlea, at least in flexion with loading the knee joint, which we've done, and so we're getting ready to publish those results right now. So you can heal. There is healing. There's a little osteophyte that's developed here at this location, but those are exceptions. And then if you notice here also in this individual, he's developed a little bit of instability as there's a little bit more posterior positioning of the lateral femoral condyle with respect to the lateral tibial plateau in 2020 than there was in 2013. And typically the distance between the posterior aspect of the lateral tibial plateau and a vertical line coming down from the lateral tibia to the femur should be less than a centimeter than normal limits. Okay. Alrighty. What do you see here? Beautiful low field study.
Yeah, so we see an ACL graft. I'm just looking at the positioning on coronal view.
Yeah, okay. Let me just tell you, there's no graft here.
Okay.
So we do have something that looks like a suture anchor here, which comes in here. This is the ACL, and this is a proximal repair, where they went in and didn't put in a graft. They kept the native ACL, put in a suture anchor, and tacked the proximal ACL back to the bone here. And this patient actually did well with this ACL repair. Again, this is not really standard. I've seen it occasionally, but not really very often.
This one looks to me like a proximal ACL tear.
Yeah, well, this is actually hardware here.
Uh,
This is another proximal graft repair of a native ACL, and that's a suture anchor placement tied in, and it looks like it's pretty tight. And this patient's knee was stable after this proximal repair, so that's another ACL repair. So these proximal areas where it's a very proximal tear, there are occasionally people now who try to repair these. You can get it right back to their native footprint. Obviously, the tibial insertion is going to be native. So the hope is that these patients will be more stable and therefore have less development of degenerative disease and meniscal tears if you repair it anatomically. And another one here. Here the actual suture anchor is not at a very good location, so I'm be a little bit worried about this one. Okay, so here's someone who had a proximal avulsion of the ACL, did the Stedman procedure, and it was not successful. He is now unstable, and you can see the displacement of that ACL. So it was a failed primary healing response. And this was another primary healing response that also failed. So in our limited experience with this procedure, we didn't have the same results that Dr. Stedman had in his series. Okay, let's see, who's next?
If that be me.
Okay, all right.
I'm just looking at the ACL. See, the anterior medial bundle looks like it's intact. I don't see the posterior bundle very well.
Yeah, here's the posterior band, here's the anterior band, and what's happening here?
There's some ACL tissue there, so maybe there's been a repair.
Yeah, so in this case, there's been a repair of that distal anterior medial band. Okay.
All right. So there's pretty amorphous looking ACL fibers near the origin, but the distal anterolateral band looks intact but a little undulated.
Yeah, so this is an old procedure, an old surgical procedure where they actually take part of the patellar tendon. It's called the Jones procedure. They took part of the patellar tendon here and put it up and attached it going over the tibia here to try to stabilize the ACL, and they put a tunnel in through the femur, put in sutures that go down to the patellar tendon, and put a button here to stabilize it. It's called a Jones procedure. This was in the pre-graft days. I don't think you'll see any of these now. Again, this is obviously not an anatomic position, so these aren't going to be perfectly stable. But if you see this and get confused by it, this is an old Jones procedure. It was done back in the 1960s and 70s. Okay.
Okay, so looking in the intercondylar notch, I think I see I see an ACL there that looks intact. Yeah, we got some prominent osteophytes on either side.
Right. So this is a ball impingement on the ACL. These can rub on the ACL, lead to degenerative disease, and eventually to rupture. Occasionally, as we talked about last time, these can be resected, but they have a tendency to grow back again. So we talked about the different locations of the bones. These have been graded like everything else in the world. Type 1 is really at the bone ligament interface at the femur. 2 is a proximal tear in the ligament itself. 3 is a mid-substance tear. 4 is a distal tear, and then you got the bone avulsions that we talked about. And types 1 and 2 are ones that some people are considering potentially repairing rather than doing graft placement for. Obviously, the bony avulsions type 4, type 5B, you need to do a different kind of surgery than a typical graft placement. One thing that people who consider doing repair of the ACL, they're really interested in the tissue quality. If the good quality, if you see nice linear striated patterns of the collagen fibers all in the same direction and homogeneous. Fair if most of them are in the same direction, but you get a little heterogeneity. But if the fibers are randomly oriented, those are not good. They don't heal well, and they're not good candidates for repair. Okay, so why don't we stop here, and we'll talk about the standard treatment for anterior cruciate ligament tears, which is graft placement, starting next week. And hopefully Dr. Yagutis will join us again then. Any questions?
Yeah, I was just wondering if these primary the repair proximally for those patients, if that fails, does it decrease the chances of success for their graft? Because the tunnel will be in a similar spot as the suture anchor, right?
Yeah, you can still do the graft. You take out the suture anchor and tunnel it in that location. You can usually do that if for some reason you've got a big bone defect there. You can take the prior surgery out, put in bone packing, let that heal, and then put in your graft. In fact, you'll see some studies where the surgeon wants us to do CTs to look for the bone tunnels to see if they need to pack them before they put in revision grafts.
Okay.
But the problem is that if they go on to have some instability and it doesn't work, and you then develop degenerative disease or meniscal tears, then obviously you're not going to have as good a prognosis in that knee as if you had put the graft in at the beginning, which might have helped protect the knee.
Okay. Thank you.
Okay. All right. Thanks, everyone.
Thank you.